Welcome to Board Pearls. This is episode 204 of the Endoscopy Practice and Sedation chapter in the Endoscopic Procedures module. In this episode, we cover the depth and agent half of procedural sedation, the sedation continuum and ASA physical status that decide who needs anesthesia, Midazolam plus fentanyl for the routine case versus Propofol for the complex one, and the alternative agents Etomidate, Ketamine, and dexmedetomidine that handle the situations the standard pair cannot. Procedural sedation has one organizing trait. The depth you want is the depth that lets you do the procedure with the patient comfortable and unaware, and the depth you can afford is the depth your team can rescue from. Those two depths are not always the same. Every other decision in this chapter reduces to fixing the gap. The agent choice, the personnel, the monitoring, the rescue drugs, and the population-specific tweaks all serve the same purpose: closing the distance between intended depth and the depth at which the patient actually arrives. Start with the ASA continuum because the language is precise and the boards test it precisely. Minimal sedation is anxiolysis. The patient answers normally, breathes normally, and protects the airway. Moderate sedation, the old conscious sedation, is a purposeful response to verbal commands, alone or with light tactile prompting. Reflex withdrawal from a painful stimulus does not count as purposeful. Deep sedation requires repeated or painful stimulation to elicit a response, and the airway may need support. General anesthesia is unarousable and frequently needs positive pressure ventilation. The clinical implication of the continuum is the rescue rule. The practitioner must be qualified to manage a patient one level deeper than the intended target. Individual response is variable, and a moderate sedation plan reliably drifts into deep sedation in a subset of patients. ASA physical status frames who is safe at what depth. Class 1 is a healthy patient. Class 2 is mild systemic disease, controlled hypertension, well-controlled diabetes, mild obesity, a current smoker, mild COPD. Class 3 is severe systemic disease, poorly controlled hypertension or diabetes, BMI over 40, stable angina. Class 4 is severe disease that constantly threatens life, recent myocardial infarction, unstable angina, end-stage renal disease on dialysis. Class 5 is moribund, and Class 6 is brain dead for organ donation. The rule that matters at the bedside is straightforward. ASA Class 1 and 2 patients tolerate endoscopist-supervised moderate sedation with midazolam and fentanyl for routine EGD and colonoscopy. ASA Class 3 and above warrants anesthesia involvement, both because cardiopulmonary complication rates rise stepwise across the strata and because the complex procedures these patients tend to need favor propofol over a benzodiazepine opioid combination. The midazolam plus fentanyl regimen is the mainstay for the easy case, and the pharmacology explains why. Midazolam potentiates GABA-A receptors and produces dose-dependent anxiolysis with anterograde amnesia. The amnesia is therapeutically useful because procedural recall corrodes tolerance for repeat endoscopy. Dosing is 0.5 to 2 milligrams intravenous initial bolus, titrated in 1 milligram increments every 2 to 5 minutes, with peak effect at 3 to 5 minutes. Total dose in a healthy adult typically runs 2 to 5 milligrams. Fentanyl provides the analgesia at 25 to 100 micrograms initial bolus, with 25 to 50 microgram increments, peak at 3 to 5 minutes, and a duration of 30 to 60 minutes. Fentanyl is preferred over morphine because the onset is faster, the duration is shorter, and histamine release is minimal, which means less hypotension and less pruritus. The synergy between benzodiazepine and opioid is the whole point of the combination, and also its dominant safety risk. Respiratory depression is multiplicative rather than additive when the two classes are given together. The clinical translation of that pharmacology is the titration rhythm. Small increments, wait for peak effect before redosing. Watch ventilation continuously rather than intermittently, and it is the reason capnography matters here more than the pulse oximeter. Propofol takes over when the procedure is long, when the procedure is complex, when the patient is ASA Class 3 or above, or when aspiration risk is elevated. The pharmacokinetics are what make it ideal. Onset within 30 to 40 seconds. A short context-sensitive half-time, which means the time to half recovery after stopping a continuous infusion stays short even after long infusions, because redistribution from central to peripheral compartments and rapid hepatic glucuronidation drive offset. Induction is 0.5 to 1 mg per kilogram, followed by intermittent 10 to 20 mg boluses, or a continuous infusion at roughly 25 to 100 micrograms per kilogram per minute. The mechanism is GABA-A potentiation through a different binding site than the benzodiazepines. The trade-off is the part that drives staffing. Propofol has no antagonist. Apnea and loss of airway protective reflexes happen predictably at therapeutic doses and must be managed actively rather than reversed. That is why airway-trained personnel must be immediately available when propofol is used, and why monitored anesthesia care is the typical service designation for propofol-based sedation in the more complex cases. Propofol also drops systemic vascular resistance and produces dose-dependent hypotension, which is why it is titrated cautiously in the hypovolemic patient, the cirrhotic patient, and the patient with fixed cardiac output. The ASGE and ASA position is that propofol-based moderate to deep sedation in healthy patients can be administered by trained endoscopist-led teams with appropriate monitoring. ASA Class 3 and above warrants anesthesia involvement. So do the complex procedures, ERCP, EUS, ESD, and deep enteroscopy. A few alternative agents handle specific situations the standard pair cannot. Etomidate at 0.1 to 0.2 mg per kilogram is the induction agent for the hemodynamically unstable patient because it preserves blood pressure and cardiac output with minimal vasodilation. The cost is adrenal suppression. A single dose suppresses cortisol production for 6 to 24 hours through inhibition of 11-beta-hydroxylase. The clinical consequence is that etomidate is avoided in the septic patient, where the adrenal axis is already stressed and a transient suppression matters. The classic stem is the patient with active hemorrhage and severe aortic stenosis who needs emergent endoscopy. Propofol drops the afterload and the fixed valve cannot compensate. Ketamine raises the heart rate and shortens diastolic filling. Etomidate is the answer. Ketamine produces dissociative anesthesia through NMDA antagonism and preserves respiratory drive and airway tone. It is useful when propofol-induced apnea is unacceptable and when an opioid-tolerant patient needs analgesia. The cost is sympathomimetic effect, raised blood pressure and heart rate, and intracranial pressure, plus emergence reactions in adults that benzodiazepines mitigate. The case where ketamine wins is the uncooperative patient without intravenous access because intramuscular dosing is feasible. Dexmedetomidine is an alpha-2 agonist that produces sedation without respiratory depression. It is the opioid-sparing choice when airway maintenance is critical, severe OSA, achalasia. The limitations are slow onset and bradycardia, which keep it out of routine endoscopy. So the depth in agent logic comes down to matching the drug to the gap between intended depth and rescue capability. ASA physical status predicts who tolerates endoscopist-supervised moderate sedation and who needs anesthesia, with Class 1 and 2 carried by Midazolam and fentanyl, and Class 3 and above shifted toward propofol. The benzodiazepine-opioid pair buys amnesia and analgesia at the cost of multiplicative respiratory depression, so it is titrated in small increments to peak effect. Propofol buys fast onset and fast offset for the long or complex case, at the cost of having no antagonist, which is why airway-trained personnel come with it. And the alternative agents each solve one problem the pair cannot. Etomidate preserves hemodynamics in the unstable patient. Ketamine preserves respiratory drive and airway tone, and dexmedetomidine sedates without respiratory depression when the airway is precarious. The next episode takes the safety apparatus that sits on top of the agents. Capnography catching apnea before the pulse oximeter desaturates, the airway predictors that decide whether the standard plan is safe before the first dose, the flumazenil and naloxone reversals, the special population modifications from cirrhosis to pregnancy, and the updated GLP-1 peri-procedural guidance. For the full chapter, the practice vignettes, and the topic-tagged question bank, head to boardpearls.com. You'll find the rest of the series on Apple Podcasts, Spotify, or wherever you listen to podcasts. That brings us to the end of episode 204 of chapter 28, and I'll see you in the next one.